Thanks, Yoshi. I'm not against anything. I'm for patients. That's really all it is. But I think I missed the title of the presentation because the debate, as far as I understood it, was for long-term outcomes in young patients. And all I heard was Notion trial and RHEA trial and Partner 3 trial. And with all due respect to 70 and 80-year-olds in the room, these are not what we define as young patients. Last time I heard young patients was maybe under age 65, maybe under age 70, and long-term is not 1 year or even 5 years. 1 year will take you from age 64 to 65. That's what the RHEA trial will answer. That's what some of these trials will answer. And the Partner 3 trial will tell you what happens between ages 74 and 78. Really not much more than that. So let's look into the data as to why I think SAVR is preferred over TAVR in the lifetime management, so long-term, young, low-risk patients. And what I will start by saying is, I'm not really going to talk about SAVR, but rather surgery, because SAVR is very reductive. It really just talks about prosthetic aortic valve replacement. And I don't think that I'll agree with one thing. SAVR may not be the best thing for young people. But what are young people? How can we define young people? Because the previous speaker said, it's not about young, it's not about age, it's about anatomy. I would vehemently disagree with that. Because young people are very different from their elderly counterparts. Their anticipated life expectancy is much longer. And if they're low risk, they don't have any chronic end organ dysfunction. They can be that 30-year-old that had a unicuspid valve, that 45-year-old father of 3 who has bicuspid stenosis, or that 55-year-old who still has about 30 years of anticipated life expectancy if you look at US life tables. 30 years. Not 1, not 5, 30. And these people have a much higher level of physical activity than a 78-year-old. Faster incidence of structural valve degeneration. The top predictor of a valve failing sooner is patient age. So it's very hard to extrapolate data in 74-year-olds, let alone in 80-year-olds in the Notion trial, to 50-year-olds. That's like saying it never snows in Florida, therefore it never snows in Canada. It doesn't work that way. 50-year-olds are very different than 80-year-olds. And importantly, having 30 years ahead of them, they have a much more prolonged anticipated life expectancy, which exposes them to all kinds of issues. So what are the goals of care in a 55-year-old versus an 80-year-old? We just talked about it with the previous case. Number one is restored survival, long-term survival. I don't care about 1 year. We're talking about 15, 20-year survival. Optimize durability of the replacement. Hemodynamics are key because young people are active. They're running around, they're running up and down stairs, they're traveling. It's not like a 78-year-old who's just going from their beds to the corner store. And we have to limit valve-related complications. So my number one point is that I agree, SAVR is only palliative in the young, and I'll show you some of that data with surgical valves. What do we know is surgical valve? We actually do know quite a bit. This is a study from Sweden. They compared the observed and expected survival in all patients undergoing aortic valve replacement, tissue or mechanical, surgical valves. And you can see that after about 7 or 8 years, not 1, 7 or 8 years, observed mortality in black is slightly higher than the expected mortality in the age and sex-matched general population. You look at this, you may think, well, older patients are probably the ones driving this excess mortality, except when they stratified the patients according to their age at the time of surgery, younger patients, that may sound counterintuitive to everybody in the room, younger patients, those under the age of 50, had the highest observed to expected death ratio in the long term at 4.5. And only patients over the age of 70 had an O to E ratio of 1. In other words, the younger you are at the time of surgery, the higher that excess mortality is in the long term. Therefore, the role of that replacement is so important. This is another study looking at mechanical aortic valve replacement, isolated elective mechanical AVR in young people under the age of 65. And excluding everything that we thought may impact long-term outcomes, everything. Mean age was 53, so pretty much the patient population we're trying to address here, and the mean follow-up was pretty long. And if you look at their survival versus the age and sex-matched general population, and this is in Canada where everybody has access to anticoagulation clinics and to care, free care and universal health care, their survival is significantly lower than the age and sex-matched general population. And survival free from reoperation was 80% at 10 years. In other words, 1 in 5 patients was dead or reoperated after isolated elective mechanical AVR at the age of 50. That's pretty sobering data. I probably shouldn't be showing you this if I'm trying to argue for surgery. You may think, well, anticoagulation is causing this. It's not. It's the prosthetic valve. This is a study from Cleveland, 3,000 tissue valves, and their conclusions were very similar. Younger patients had worse than expected survival that was further diminished with insertion of a small prosthesis, introducing 2 notions. One, Age does matter. It is incorrect to mention that age doesn't matter anymore. It's only anatomy. Age matters. And small prosthesis, hemodynamics matter a lot when you're young. It doesn't matter if you're 80, but it matters dramatically when you're 50. Another study from France, over 2,500 tissue aortic valve replacements. And what you see in the x-axis is the age of the patients at the time of surgery. In black is the observed survival after tissue AVR, and in gray is the expected survival of the French age and sex matched general population. And again, look, the younger patients have a much bigger gap in expected survival or in excess mortality versus their older counterpart. Only once you reach the age of 70 is your survival pretty much equivalent to the general population. Remember, age does matter. Another study from Sweden, the Swede Heart Registry. Every single patient undergoes surgery is included in that study. And again, when they stratified them by decade of age, only those over the age of 70 have an O to E ratio equal to 1. Everything that is younger has an O to E ratio superior to 1 for mortality. Age matters. So why are the results so imperfect for young people? Why is it only a palliative rather than a curative approach in young people? A, because of hemodynamics, and 2, because of biology. And patient prosthesis mismatch is common after aortic valve surgery. About 40% of the patients who leave the OR will have some degree of moderate to severe patient prosthesis mismatch. And I'm sure all of you are thinking, well, with TAVR, we have better hemodynamics. Not correct. The hemodynamics are exactly the same. In fact, if you look at the impact of patient prosthesis mismatch, it impacts the rate of structural valve degeneration, survival of the patients, survival after a valve-in-valve procedure. So it really is important, particularly in young people. And look at the 1-year echo data in the PARTNER 3 trial. These are 74-year-olds, so the valves, should perform quite well. Mean gradients over 20 at 1 year. 1 in 10 of the patients that received the SAPIEN 3 already has a mean gradient of over 20. Already has moderate stenosis 1 year after surgery in a 74-year-old. And the second point is the aortic root is a living structure. The biology is very important. I spent 4 years looking into this. This is the title of my PhD thesis. I'm not going to bore you with it, but this one slide. We're all very familiar with the importance of vascular physiology, endothelial function for vascular physiology, and for our longevity in general. The valve is no different. It has a single layer of endothelial cells. It has interstitial cells in the body of the leaflet. There's smooth muscle cells. They can contract, relax, they adapt. That's why the mean gradient across your aortic valve is in the single digits, whether your heart rate is 60 or 160, whether you're running or walking or sleeping, it does not change. Why? Because it's living, it adapts, unlike a prosthetic valve. And so how can we best preserve or restore biology? There are only 2 operations to do so. Either we repair the valve for patients who have AI, or we replace the valve for those who have a Ross procedure. So the second point is the Ross is really the optimal SAVR operation in the young. And there's a lot of data in the literature. This is a great state-of-the-art review that was published a few years ago, still very relevant, but the data is abundant, overabundant, last 10 to 15 years. Every single study from all continents and countries, including randomized trials, have demonstrated superior equivalent survival in the long term in patients after the Ross versus the general population, and better outcomes than compared to a tissue or a mechanical valve. And most recently, we published this year the very long-term outcomes, median follow-up of 24 years with a 98% completeness of follow-up, and survival continues to mirror that of the age and sex matched general population. There's no operation like it. And more recently, I presented at the AHA the contemporary outcomes of my inaugural Ross series from Canada, 450 consecutive patients. Data was prospectively collected. The average median follow-up is 8 years. Average age of the patients is 48, and half the patients are over the age of 50. As far as I understand, this is what we're debating today. The valve lesions were AS in the majority of patients, and these were the results. Most significantly, there is less than 1% rate of pacemaker implantation. That's important. It may not be important in an 80-year-old. It is very important in a young patient. And there is no PPM. There is no PPM, 0 PPM. And this is the survival at 12 years, similar to the general population. Reintervention rates are very low. Cumulatively, it's 1.4% at 12 years. Pulmonary homograft reinterventions, 2% at 12 years. All cardiac reinterventions, 4% at 12 years with a normal survival. I'm not talking 1 year or 3 or 5 years. And these are women and men in small annuli, big annuli, bicuspid, tricuspid, mean gradient of 4 over time. And that's why you're seeing that Ross renaissance in the US in the last 5 years. The volumes have now increased tenfold in the last 10 years because of these data. So instead of thinking the traditional way about valve options in young people. Do I want to open? Do I want to keep them away from work for 3 days or 3 weeks? And the balance between anticoagulants and reoperation. To me, they're all one and the same. They're all acellular, non-living substitutes with absolutely no potential for growth, repair, or adaptation. And my last point is that we have even worse issues with a TAVR in the young versus a SAVR in the young. Forget Ross or repair. Why is that? A, because of the higher risk of pacemaker and the higher incidence of left bundle branch blocks. We know it from the low-risk trials. The incidence of TAVR is way superior to of PPM or pacemakers and left bundles is significantly higher whether you use one valve or the other valve versus surgery. And the impact of that is very bad. Not at 20 years. Look at this meta-analysis and increased risk of all-cause deaths and heart failure hospitals at 1 year. That takes you from age 74 to age 75. What about the higher incidence of PVL? We said mild PVL is 1 in 5 of the patients after in the PARTNER 3 trial at 5 years. 1 in 5 of the patients has mild PVL. It's not important if you're 80, but I guarantee you it is significant if you're 50 years of age and you're trying to run a marathon. TAVR explant risk, we talked about it, the risk is higher. Yes, these patients were sicker initially, but I'm a surgeon doing this every day. It is not like removing a surgical valve. It is different. And often enough, it involves the mitral valve and other things that are not intended initially. Coronary access is an issue. You know this better than I do. And most importantly, young people are mostly bicuspid and unicuspid. So everything that was presented earlier by the previous speaker has nothing to do. Why? Because in every single study, bicuspid valves were excluded. And the only data we have about bicuspid TAVR is in highly selected patients. And believe me, I operate on bicuspids every day. They are very heterogeneous. To try to put bicuspids into one category is a fallacy. They come with ASAI, type 0, type 1. Commissural orientation is different. Everything is very different. Almost half the patients have some degree of aortic dilatation. All these patients are young. And beware the hype and follow the evidence. You see all these cases on Twitter. I go on Twitter occasionally to see what's happening. I did a great basilica and TAVR and this and that and a bicuspid. Twitter is not science, unfortunately. Science is a little different. Science shows us that when the raphe is calcified, it can be pretty treacherous with all-cause mortality at 720 days. 720 days, that's not a whole long time. And the Notion 2 trial, which actually looked at bicuspid TAVR, shows, again, pretty sobering outcomes when it comes to TAVR and bicuspids. And again, these are highly selected patients. This is not all-comer bicuspids. Our surgical results in bicuspids are better than in tricuspids because these are younger patients. So compare all this together. I'm going to conclude here. So young patients, age is the top predictor of structural valve degeneration. I could not disagree more with the slide that says age is not important anymore, it's only anatomy. Outcomes in 70 and 80-year-olds have nothing to do with outcomes in 40, 50-year-olds. Nothing to do with it. Bicuspids is not tricuspids, and we know very little about TAVR and bicuspids except in very highly selected patients, and the data is rather sobering. Younger patients are more disproportionately affected negatively by pacemakers, by patient prosthesis mismatch, by left bundle branch blocks, by PVL, and all of this is more frequent with TAVR than with SAVR. And Ross or aortic valve repair is significantly better than SAVR, so imagine. So instead of having a single tool and seeing everything as a nail, it's important to, I know we talk about heart team, but let's put the patient in the middle. Not their preferences, but let's center the treatment around the patient-centered approaches rather than patient preference. My kid, I have 3 kids under the age of 5. They all love eating candy every day. This is their preference. But does that mean that this is the best treatment for them? No. Vegetables are better. So patient preference, of course, everybody wants a little catheter thing. But does that mean it's better for them? No. And these are all the tools we have. We have to tailor them, we have to discuss, and we have to be driven by patient well-being and by science. And feasibility does not automatically mean long-term benefit. With all due respect to my TAVR colleagues, it is not just about I can do it or can I not do it, and like my previous speaker spoke, the anatomy. It is about what is the long-term benefit and what are the goals. In young people, it's survival, quality of life, durability, etc. We have to tailor the approach to many things in addition to the anatomy, and surgical expertise is, of course, important. Thank you.
Okay, well, they're going to be ready for you, but I have to make one comment as well, just because I enjoyed that a lot. But there's a real fallacy here, and I really want to challenge everybody, because a lot of you, the interventional cardiologists here, that whenever you guys showed me the stent data for the last 25 years, there was always another stent. We solved that problem. There was a lot of progression, and we always reminded ourselves that the data can only get better. The surgical trials, just so all of you are aware, like when I see these data that suggest that TAVR outperforms surgical valves, I wish everyone would just get educated, because we're having an academic conference. The valves that were used in that Medtronic trial, and I was a national co-PI of the core valve trial, so I know a little bit about it. The valves that were used in the Evolut trial, a majority, 40 or 50% of them were Percival valves, or they were trifecta valves, which are off the market now for the failure at 8 years. And Mike and I were just talking. We wrote an editorial in Jack about this. There are many surgical valves that were going to be the savior of surgery that were off the market within a decade for stenosis and failure. So I really think we have to be very thoughtful. I think we have to be really thoughtful about knowing all the data, not just being happy with the curve or the abstract, but understanding when surgeons see that paper, we've dissected it very differently. That's how those valves, one of the reasons they're off the market now.